This is Module 30 on spirituality and includes the exemplar A, spiritual distress, and B, on religion. Some terms. Religion is a system of beliefs that offers explanations and practices to allow coping with life's questions and challenges. Spirituality is the essence of being human, reflection of inner experience of meaning, connection, transcendence. Spiritual development, ongoing growth of experience and integration of meaning and purpose in life. Spiritual well-being is a pattern of experiencing integrating meaning and purpose in life. Spiritual distress, a challenge or feeling of dissatisfaction with one's spiritual well-being or with the belief system that provides strength, hope, and meaning to life. That's spiritual distress. All these definitions are to 2023 through 2024. Spiritual needs. A patient may find beliefs challenged by their situation. They may hold beliefs more firmly and appreciatively. They may get more stubborn with it. Patients with no defined beliefs may be facing challenging questions, looking for a meaning. Examples of spiritual needs are need related to self, related to others, related to ultimate other, and among and within groups. Spiritual needs, you see that's listed down there in box 30-1 on the bottom of 2024. Needs related to self, for meaning and purpose, expression, hope, gratitude, prepare for and accept their death. Needs related to others, need to forgive others, cope with the loss of loved ones. Ultimate other, certain there is a God or ultimate power, need to worship, need to believe that God is loving and present. Need among and within a group, need to contribute or improve one's community, need to be respected and valued, need to know what and when and to give and to take. Religion. Page 2024, 2025 gets into religion, a system of beliefs and practices that may or may not help them cope with life's questions and challenges. Religious rules of conduct may apply to matters of daily living. Concurrently with their culture, it's a blend. Whether institutionalized or not, provides means for awareness of an expression of spirituality. Beliefs address the questions about nature and humankind, how it came to be, their purpose, suffering, and what happens after death. Generally involves beliefs in relationship with a higher power, creative force, divine being, or an infinite source of energy. There's a safety alert on page 2025. Thinking about spirituality only as religion can cause an unethical stance toward non-religious patients that is insensitive and domineering. Conversely, conceptualizing spirituality without a religion can contribute to your insensitivity to the patient. So we have to be open. You become who they need you to be when you are in the room. Morality and ethics on the bottom of page 2025. Ethics guides your determination of what is right, what is wrong. That's your ethics, where your morality is society has created to promote ethical conduct of right and virtuous behavior. So, and applying values, assigning meaning or inherent ethical moral decision making, and it can be related to your spirituality. 7 stages of faith development. Infancy to 3 years, undifferentiated. Age 3 to 7, intuitive, projective. The child acquires spiritual properties of trust, mutuality, courage, hope, and love in their infancy to 3 years old. When they hit intuitive or projective faith, that's the toddler with their magical thinking and their reality start to overlap. If you've been around toddlers or have a toddler, it's interesting their talk of God and nature and things, because everything interacts. The third stage School-age children, that's age 8 through 12 years old. Mythical or literal faith, they accept stories, they believe it literally exactly what you say. Stage 4, synthetic, conventional faith, that's in adolescents and teens, sometimes into the young adult, generally conform to the beliefs of those around them. And then the 5th stage, individual, reflective, young adults and later adulthood, the development of their self-identity, worldview, differentiate their view from everybody around them. They come up with their own. Conjunctive faith, that's the adult past the midlife. They have a new appreciation for the individual's past, they value their inner voice, become aware of their myths, prejudice, images. Then the last, universalizing faith, which is infrequently reached. It's a sense of inclusiveness of all being. At least that's the 7 stages of faith development. Spiritual history and observation, that's your FICA tool. Page 2029. Gotta find it here. It's on the far column of 2029. Faith, implications, community address. So faith or beliefs that are important. What spiritual beliefs are most important to you? This is the most common spiritual history tool, your FICA. Implications or influences on coping. How is your faith affecting the way you cope now? That is an open-ended question. C, for community availability, is there a group of like-minded believers with whom you regularly meet? A, address the need for spiritual support. How would you like your healthcare team to support you spiritually? Patients who are not religious, will be important to select language that is not religious. So it gives you some examples of not religious. The most commonly used spiritual history tool is this FICA tool. Spiritual practice affecting nursing. Beliefs affecting diet, what permitted foods and prohibited foods, and certain types of fasting. Beliefs related to healing. Some religions view illness and suffering as a test of faith and an opportunity for spiritual growth. Beliefs related to dress. Rituals and traditions. Head coverings, undergarments, conservative clothing, covering their body. Beliefs related to birth, ceremonies for newborn and mother, placenta baptism, circumcision. Beliefs related to death. Some religions have special rituals for dying. Healthcare providers should assess and incorporate patients' dietary, fasting beliefs, meals, prescribed diet plans. This is all page 2030 to 2031. Yep, all the way into 2032. Ethical conduct in spiritual caregiving. First, seek basic understanding of the patient's spiritual needs, resources, preferences. Follow patients' expressed wishes. Do not prescribe or urge patients to adapt a certain belief. Do not pressure them to relinquish their beliefs. That is not ethical. Let's see. Engaging community-based spiritual care. It's page 2033. Respite care for caregivers, that's often missed. Financial support, organizing help with meals, household duties, visit the sick, faith community nurse. These are things that can be in the community that you can help link up this patient with. And I didn't include it here, did I? No. So on the top of page 2033, box 32, spiritual self-care for nurses, learn and practice mindfulness. That is to be tuned in mentally, emotionally, and physically to what you are experiencing in the present moment. Recognize your own woundedness. We just go and go and go and keep giving, and we forget for our own healing. Be as compassionate to yourself as you are to your patients. That's a biggie. Experience self-compassion. Remember, there is a compassion accord in every every person. And notice the opening of your heart with compassion toward others when you realize that their woundedness essentially mirrors yours. When you find yourself irritated or lacking compassion for a patient or colleague, appreciate the person is functioning as a mirror and can teach you what needs compassion within yourself. Okay, I just thought I would go over that little box with you. Collaborating with chaplains, provide assistance with religious rituals, provide support for families with emotional, ethical, spiritual concerns. Nurses can make referrals to chaplains and elaborate them. Patients visited by chaplains are more likely satisfied. Table 30.1. Oh, whole big table on 2034. Spiritual therapy. There's several different: altruism, awe, expressive artwork, dignity therapy, gratitude, mindfulness, writing papers, spiritual expression. These are just some things to kind of be familiar with. Also, explaining to patients that a chaplain is not necessarily religious. They are there for whatever their spiritual needs are. Spiritual distress, module 30A, starts on page 2035. Characteristics: lack of hope, meaning, purpose, forgiveness, intimacy with divine, anger or lack of interest about previously spiritually nurturing people or resources. Their individuals in their spirituality are complex and variable. There is no list can include everything. Nurses must be aware to provide holistic care when promoting healing. On page 2036 goes into the nursing process. Your assessment: determine the patient's spiritual beliefs, build the nurse-patient relationship, elicit information. Elicit, don't force it. Open-ended questions. And the previous, in the concept, it gave you key kind of questions to ask and how to pull it out. FICA tool is an excellent one for that. Brief spiritual screening improves chaplain referrals, improves outcomes, fewer harmful effects of spiritual distress. Ask open-ended questions. The nurse is not there to provide spiritual guidance, just to get these resources the person needs. Nursing diagnosis can be fear, chronic or situational low self-esteem, disturbed sleep pattern. I'm not going to read those to you. Okay, so fear can be related to apprehension about the future. Low self-esteem, because related to failure to live within expectations. Disturbed sleep pattern related to spiritual distress. Coping ineffective related to abandonment by God or loss of their faith. A decision conflict between treatment plans and religious beliefs, or some nursing diagnosis. Your goals are listed here, also listed in your planning section on page 2036. Implementation: some things that can help recognize, validate the inner resources of an individual, assist the patient to leave a legacy by storytelling or recording life stories, keep in touch with nature, a sense of wonder, providing inspiring story about how someone in a similar circumstance maintained hope and grew spiritually, point to orderliness of the universe. These are some possibilities for spiritual care. Most important thing the nurse can do is to be present to the patient in ways that communicate hearing, accepting, and not judging. So here, providing presence, 2036, 2037, it's kind of spread there, just being there, but purposefully attentive. I'd like to, this little saying was why I put it in there: to be truly present with someone is the best present. Be slow and calm. Make sure in your heart that you are willing to be present. Sit down, remain at the patient eye level, allow silence, smile or give a positive energy while being respectful of their emotional state. Focus completely on the patient, empathize, with the patient actively, deeply listen. Self-disclosure is never appropriate unless the patient asks for it or it has a therapeutic intent and not a self-serving. You're not there for your healing. Spiritual counseling referral, page 2037. Refer patients for spiritual counseling. Work through the hospital chaplain's office. That's if they're hospitalized in the community. Outside counselor, looking for resources. Maybe your social worker can help you with that in a home health setting or clinic setting. Evaluating your outcomes, 2037, 2038, and it has a care plan there. So there's a really good care plan to walk you through the steps, identify purpose of activities, ways of thinking, articulate a sense of hopefulness. This is where you hope they're going to be finding meanings in their existence. We're going to move right into 30B, religion. Common characteristics of a religion, whether it's a God or a higher power, direct communication, ethical or moral code. This is on 2039. It's organized, it's a communal approach, provides with constructs of beliefs, moral values, typically practiced in a community setting. Components of religion, they have holy days, sacred writings, sacred symbols, prayer, meditation. Holy days are set aside for specific sacred writings or authoritative scriptures. Sacred symbols may be worn, may be statues. Prayer meditation may dictate times for prayer, meditation, and worship. Need to be aware of this. Aspects of religion that affect medical care, page 2040. Breaks up your different, so Buddhism, practitioners typically embrace Western medicine. They cure through the mind and herbs does not mean they will refuse Western medicine because they traditionally will go ahead and follow it. Hinduism may add alternative therapies from their culture, usually practiced by those from India and Southern Asia. They usually will go ahead and embrace their Western medicine mixed with their culture. Generally value cleanliness, believe they have more than one life, ceremonial rites practiced at dying immediate after death. They may prefer not to use medication derived from animals, and they may choose not to participate in organ donation. Islam, 2041, may see illness or death as God's will, healing only through God's will, cleanliness, modesty, very important. They prefer that nurse be of the same gender if possible. That's a key, because if possible, you will be able to provide that. Dietary practices avoid overeating, alcohol, pork-based things. So that's part of when you're putting in your stuff for the dietary to know. Fasting during Ramadan. Pray 5 times a day. Second largest religion in the world. If not possible to have same-gender nurse, allow same-gender colleague or family member to be present. Leave door ajar if the patient's not physically exposed. Touch the patient only when conducting procedures. Judaism may or may not keep a kosher diet just because they claim that. You just need to ask these questions. They have certain days and times that they pray 3 times a day in a group, possibly prescribed rituals regarding death and dying. That's for the Judaism. And the Judaism and Hinduism may include abstaining from healthcare activities, Judaism on the Sabbath. Kosher diet is avoiding pork and shellfish, not mixing dairy and meat. I know when I was working, I would get the Islamic mixed up with it. This Islamic avoids alcohol, pork, and pork-based, and the Judaism avoids the pork and also shellfish. Don't mix the dairy in the meat. They often want the rabbi present near death, and the body needs to be buried as soon as possible, preferably within 24 hours if possible. Christianity, belief, body is a temple of God, generally embrace rescue medicine. They differ on birth control, abortion, same-sex marriage, and Eucharist is Holy Communion in some of the religions, Christian religions. There's multiple different ones. You go into this more again in community health, just knowing some of these that will affect it, like the Amish may not have health insurance and refuse expensive health care. Christian Scientists typically oppose Western medicine. Jehovah's Witness refuse any blood products. You have to discuss alternatives. Latter-day Saint avoid alcohol, coffee, tea, smoking, may wear temple undergarments. Seventh-day Adventists likely to avoid unnecessary treatments, often vegetarian. Christianity continued. There's Roman Catholics, Orthodox, no special things there really other than having a sacrament and a priest. Your assessment, the longer they're there, the more important it is to find out about their needs. Any patient with a threat to life should be assessed for religious practice, spiritual needs, inquire about religious using non-religious language because it could be spiritual. Here's multiple diagnosis, nursing diagnosis. I'm not going to repeat all of them. They are listed in your text. On page 2043. Their goals: be able to participate in religious observation, participate in prayer, prescribe times, receive the meals that comply with what they believe, and have access to religious resources. Box 30.3 on the bottom of page 2043, supporting religious practices. I think I have gone over all those. You may want to read over those. Implementation. That's really what box 30-3 is. Assist patient with prayer. Prayer boosts emotional, spiritual well-being. People are more optimistic when others are praying for them. Tell patients you are praying for them can be positive. Should only be done by mutual agreement. If a patient asks you to pray with them, if they want to pray, you can close your eyes. You don't have to actually participate or believe, but you allow that. And don't force your belief or your prayer on them unless that's something they want you to do. Arranging with dietitian for a patient's dietary needs. Allow time, privacy for private prayer, worship. Don't discuss personal spiritual beliefs unless they ask for it. When a patient asks for prayer, that's on box 30-4 on the top of 2044. You need to read over that. Illness can interfere with the patient's ability to pray. Barriers can be anxiety, fear, guilt, grief, despair, isolation. They may ask the nurse to pray with the patient, or they may want to pray privately but need to be open to you. So read box 30-4. Evaluation. Patient has been provided opportunity to practice their beliefs. Nursing dietary staff made appropriate considerations. Nursing and dietary patients successfully maintain connection with religious practice and belief. And that is the end of this recording.